And basically what CJR is going to do is it's going to say that the hospital is responsible for the entire cost of a bundle of care that starts on the day of admission and runs 90 days following the discharge if the patient is coming in for DRG 469 or 470. The hospital is going to receive a bonus or a penalty based on whether or not it meets a target price, and also, and it's important not to forget, patient satisfaction and outcome measures, because if you fail on the patient satisfaction or outcome measures, no matter how you fare on the price measure, you aren't going to get the payment. So one of the counterintuitive parts of CJR is that no one besides hospitals are required to participate. So a hospital is in the program. Therapists, physicians, skilled nursing facilities, they are not in the program. They're going to bill just like normal. So a hospital can, but isn't required, to provide some incentive to these other organizations to work on the program. And those other organizations are called, within CJR, collaborators. So these other providers aren't at any sort of risk. They just bill like they've always have. And so if they don't enter a collaboration agreement, nothing changes for physicians, skilled nursing facilities, and therapists. So one of the terms of art here is a participation agreement, which is similar in idea to gain sharing. And it's the idea that the hospital can share the gain it gets and then potentially share the losses with other participants. Now, legally, not a lot is going on here. Practically, the impact is going to be huge. So let's go to some of the big 4-star questions. So first off, can a hospital require patients to use maybe a particular physician or a particular physical therapist or a SNF and say, hey, this person has entered into a collaboration agreement with us, you have to go there? And the answer to this question is a resounding no. The freedom of choice rules apply, and hospitals can't require patients to go to a particular place. They can recommend that patients choose a particular physician or therapist or skilled nursing facility. They can say, hey, we have relationships with these providers and suppliers and we hope you'll use them. They simply can't require it. In fact, hospitals are required to notify patients about the organizations that they have collaboration agreements with. So there's nothing wrong with recommending, you just can't require. Can a hospital require that a collaborator agree to a contract? Well, that's actually, this is kind of I poorly worded this question, because the real question is, can they require a physician or other professional to become a collaborator? And the answer to that question is no, they can't. A physician is free to say, no, I don't want to have anything to do with that, and continue with life as normal. However, if a physician or a therapist wants to be part of the program and wants to get payments by a hospital, then they do need to enter into a written agreement with the hospital. If you're a potential collaborator, you're a physician, can you share gain from the hospital without sharing in the downside risk? And the answer is absolutely, yes. It is possible to have an upside without having the commensurate downside. Now, if you enter into a risk-sharing arrangement, there are a whole bunch of legal requirements that are triggered. So first, you have to have a written agreement that establishes the terms before any care is furnished to any patients. And that agreement has to have a whole bunch of various factors in it. So it has to have quality criteria that you agree on and that the collaborator is going to have to satisfy in order to get any payment. The total distribution that's paid to a physician in any year is capped. And the cap is you look at the total Medicare fee schedule payments that are made to the physician, and 50% of those payments, and this is that are made to the physician for services to CJR beneficiaries. You look at the total Medicare payments, the distribution payment can't be more than 50% of that total. So that's a firm cap. So if let's say the physician provided $1,000 worth of physician services to CJR beneficiaries, the most they can get is $500. Even if they saved the hospital $3,000 one way or another, they're still capped at a $500 payment. Only physicians who actually perform CJR services to beneficiaries, or to CJR beneficiaries, for at least one episode of care can get any portion of the gain sharing payment. So if you've got either a multi-specialty group or either in a single specialty group and only some physicians are providing services at this particular hospital to CJR beneficiaries, only those physicians can get the payment. The clinic can't take money and distribute it according to its normal compensation formula or distribute it evenly or anything like that. The money can only go to physicians who participate in the CJR program. Now the program allows hospitals to recoup money from a collaborator if the hospital has to pay money back to CMS, because remember, it's there's a bonus penalty provision here. But the hospital can't recoup money from a collaborator unless the hospital has to pay money to CMS. And then when it recoups, there are some caps here. The hospital can't recoup more than 50% of what it owes CMS. The hospital has to stay on the hook for half the loss. And no collaborator can be responsible for more than 25% of what the hospital owes CMS. Now, all of that said, there's some opportunities for flexibility here. So the sharing can be based on the amount that the hospital is paid for its savings, or you can also have payments that are based on internal hospital savings or a combination thereof. And as long as you satisfy Stark and the anti-kickback laws and tax exemption laws, you can structure these payments pretty much any way you want. So if a clinic gets the money, how can it distribute the money? Well, as we talked about, only physicians who are actually involved in an episode of care can get any payment. That said, payments don't have to be equal, and in fact, arguably, it's going to be difficult for them to be equal because they're supposed to be based on the physician's contribution. And it seems like CMS really wants payments to be related to work, so a non-equal distribution is going to be more the norm